for for providing me the opportunity to speak on this platform today. As I said at the introduction already, the ENIGMA-Sleep talks have been a great resource for discussion also in Australia, and it's a big pleasure for me to present here. So my name is Rick. I'm a neuroscientist by training. I'm mainly interested in really how the brain works and focusing on memory consolidation of emotional memories during sleep and how the brain accomplishes that. And I do that not also by studying how things might go wrong in people with sleep disorders. So I'm studying both healthy controls and people with sleep disorders. And in this case, I'll be focusing on the work that I've been doing in Amsterdam at the Netherlands Institute for Neuroscience, and also some more recent studies that I've been doing at the Woolcock Institute. And hoping to get you some more insights into the mechanisms of overnight regulation of emotional distress. Very quickly, just to highlight what insomnia is, I'm just listing here the diagnostic criteria. So insomnia is when people have difficulty initiating sleep or have lots of nighttime awakenings, and especially those will be very relevant for today's talk. Or they wake up too early in the morning without the ability to go back to sleep. Now, this must also have daytime consequences, and most commonly you would hear about sleepiness, fatigue, or cognitive problems or memory problems. And then also, this is not just an incidental bad night of sleep. So with insomnia, they need to have this at least 3 times per week for at least 3 months in a row. The hyperarousal model of insomnia, which was originally proposed by Bonnet et al., but also further worked on by Riemann and his colleagues, it has been really the main framework, or one of the frameworks that were really relevant for my work, basically since I started my PhD here in Amsterdam, where it postulates that insomnia can be subdivided into the acute, subchronic, and chronic phases, which is paralleled also with adaptive, but also maladaptive sleep behaviors and responses in the central nervous system. And the idea is that an initial stressor or maladaptive sleep behaviors can be related to disturbances in the ascending reticular arousal system. That's the arousal system in the brain that is seated by the locus coeruleus, the noradrenergic system, which is very much relevant for today's talk. But also, for example, with disturbances in homeostatic sleep regulation, and that could be, for example, linked to differences in activity in the VPLO, for example. Now, if these stresses are really intense or lasting, or the maladaptive sleep behaviors are lasting, then we can also see, as compared to healthy sleepers, increased cortical hyperarousal reflected as increased high-frequency EEG activity. We can see this both in sleep, but also during wake, for example, in the evening, pre-sleep. And this also is related to the impaired memory consolidation, as I'll be showing you today. And we have strong ideas about that being the main factor that links insomnia as a risk factor for developing depression and anxiety. So just highlighting here that the factors that would be most relevant for today, but it's in a wider framework, of course, will be the ascending reticular arousal system seated by the locus coeruleus, cortical hyperarousal, and how that links to impaired memory consolidation. I always like to sort of start with this slide about normal sleep, because I think it's quite important to stress that normal sleep already has different levels of arousability. And so when you consider the normal sleeper, we see the different sleep stages on the vertical axis and time on the horizontal axis. And you can see the normal sleeper has really robust sleep cycles with very long bouts of non-REM and REM sleep. But importantly, there's also some awakenings and arousals. And these awakenings and arousals can be observed in the EEG as short-lived high-frequency EEG activations, shown here in the EEG trace and in the spectrogram. And this is also related to, again, that locus coeruleus, the noradrenergic activity, part of that ARAS, the arousal system. And so work by Anita Luthi's group and others have really linked this all together, showing that the noradrenergic systems showing increased activity for and decreased activity in periods for about 30 to 100 seconds. So this noradrenergic locus coeruleus activity goes up and down during non-REM sleep. However, during REM sleep, this system is very strongly inhibited, right? So we have a very strong inhibition of this locus coeruleus activity. And then we know that these arousals and these awakenings are strongly linked to that activity of that system. Now, importantly, if we consider then the sleep of insomnia, we can also see that they have lots of these arousals and these awakenings, but if we quantify them, we actually see that they have this increased number of arousals, the arousal density or the arousal index, predominantly peaking in that REM sleep, which was supposed to be that time when this noradrenergic activity should be on an all-time low. And so we were quite interested in following this up and really studying these phenomena and linking that to memory consolidation. But you might ask, okay, but how would you propose this would impact memory consolidation? Well, that's very same work by Anita Luthi's group has shown that the noradrenergic activity and the spindles, so the sigma frequency range in the EEG, is anti-correlated. So that means that you'd get these sort of packets of when you have lots of spindles in periods when this noradrenergic activity is in its troughs, so the low activity during non-REM sleep, whereas these spindles are largely absent in times when this noradrenergic activity is peaking in this noradrenergic activity. And we also know that the theta rhythms that is the predominant feature of REM sleep can be disturbed by noradrenergic activity. And both sleep spindles and theta activity have been implicated in the overnight regulation of and consolidation of emotional memories. And so that was really the main ideas behind linking all this together. And we started out with a neuroimaging study that I would like to present here that would search for some evidence of these types of mechanisms. So in this slide, I just want to highlight a little bit what we did. In this case, we wanted to induce emotional distress in the evening, then had participants sleep in the laboratory, and then we asked people to recall and relive that emotional experience in the morning. Again, we did the purple dots here in the MRI scanner, so we could observe how the brain activations were in the evening and how that changed overnight as a function of that sleep. Now, the emotional stressor that we chose to use was based on the karaoke paradigm, in which we asked people to sing a song, of which nobody could fully do that adequately, and also we made sure that the song that they were singing was not replayed back to them at time of recording, so they couldn't perform the recording very well. And we also validated this paradigm to induce embarrassment and shame. So this was quite a nice, robust, really self-referent, self-important emotional stressor. More so than, for example, showing emotional pictures. And the idea was then that in the evening, both normal sleepers and normal sleepers and insomnia patients would reactivate the limbic brain response to the same extent. We didn't necessarily expect that insomnia patient had an initial stronger response. We expected to see the differences to appear after a night of sleep, where the hypothesis was that with normal REM sleep, you could adapt that emotional limbic brain activation, showing a decreased response in the amygdala, for example. Whereas with this restless REM sleep, we expected the amygdala response to be maintained, to sustain that activity. As for the results, here on the left side of the slide, I'm showing that limbic brain activation, highlighting that activity in the amygdala. And indeed, as expected, we couldn't find any group differences between insomnia patients and controls, really confirming that it's not necessarily the initial emotional reactivity that is increased in insomnia. They reactivate to the same extent. The differences really appeared after a night of sleep, and we could indeed show that the overnight change in the amygdala reactivity towards this task was associated with the REM sleep duration. And the negative association indicates that with more time in REM sleep, there was a stronger overnight adaptation, so a decrease in that amygdala response. Now, we found two very important interaction effects. The first one I want to highlight here is the interaction with the non-REM sleep spindles. And I just have to explain a little bit here about how we quantified these spindles. So based on this animal literature, we also know that this non-REM sleep can be subdivided into the descending and the slow wave sleep arm, and then the transition to REM sleep. So that little period of non-REM sleep prior to REM sleep is rich in spindles. And so we quantified these spindles specifically to this period just prior to REM sleep, which is called the transition to REM sleep. And we found that when you had lots and lots of these spindles, then the effect of REM sleep was augmented. In other words, we saw that the effect of REM sleep became even more negative when it was preceded by lots of spindles. So there's really an important interaction effect between non-REM and REM sleep together that then together help to adapt the overnight limbic brain response. Importantly, also with the interruptions, we found the opposite interaction effect. So that meant with more and more interruptions and fragmentation of this REM sleep became increasingly less able to adapt the overnight limbic brain response, even up to the point that if you consider these 95% confidence intervals, you see that when you have lots and lots of these interruptions during REM sleep, then the effect of REM sleep becomes basically zero. So there's no longer any effect of REM sleep. So taken together, what we have shown here is that indeed sleep is important for the overnight regulation of emotional distress. REM sleep plays an important role. With more time in REM sleep, you can adapt the amygdala response even better. And this effect of REM sleep is dependent on the spindle density, but also on that fragmentation of REM sleep. Later, and this is work by Risto Halonen in 2021, they used the very same paradigm. So again, the karaoke paradigm, they asked people to listen to their own out-of-tune singing. But in this case, this wasn't a neuroimaging study. They used the galvanic skin response, so an autonomic measure, measuring basically how the sweatiness of your hands. So basically that autonomic response. And they too could show that in that sleep and REM sleep specifically was associated with the overnight adaptation, but only if this REM sleep was not fragmented. This work also nicely aligns with earlier work by Els van der Helm, showing that if you view negative images to healthy sleepers, then REM sleep helps to depotentiate that amygdala reactivity. But again, only if that REM sleep doesn't have a lot of high-frequency EEG activity. Using a fear extinction memory paradigm, this was also in line with findings by Ryan Bottery and colleagues, showing that the fear extinction memory consolidation is negatively associated with REM sleep in insomnia, not in normal sleepers. And they didn't directly investigate the role of arousals, but they do mention in their discussion that arousals might have well been able to explain the findings. And then finally, I also would like to highlight sort of the other way interaction. So in this case, this is work by Insana and colleagues that investigated early life trauma and show that with more early life trauma that's associated with REM sleep fragmentation in adulthood among military veterans. So the links could also be related to stress-inducing maladaptive sleep. So it's a very interesting sort of field of research to be in. It's very active and it's very exciting. And so the studies so far have basically considered the effects of a single night of sleep. But as I mentioned at the very start of my talk, insomnia is not necessarily just an incidental bad night of sleep. They have this at least 3 nights per week and at least 3 months in a row, and often for years and years on end. So in our studies, we also asked what are the long-term consequences of insomnia with respect to these emotional memories. And to that end, we did a very large survey-based study in which we asked just under 1,200 individuals how often does distress from an emotional event last for? And then we had options such as a few minutes, a quarter of an hour, up to more than a week. We then also performed a factor analysis in which we could confirm there were two different factors. The first one being the short-lasting emotional distress factor, which included items that indicated resolution of that emotional distress within an hour, so quite short-lasting, whereas the long-lasting distress was longer than a day, so a whole day up to more than a week. And interestingly, the long factor then also includes a night of sleep, right? So that's the important distinction between the long-lasting and the short-lasting distress, where long-lasting distress includes a night of sleep. We then went on to associate these two factors with the insomnia severity index. And firstly, I want to highlight here the green line. We could not find a significant association, meaning that it doesn't matter whether you're a healthy control or whether you have severe insomnia. Everybody regularly, up to regularly, experiences this short-lasting distress, indicating maybe also reasonably the same as what I said earlier. It's not necessarily that the insomnia patients have an increased reactivity to emotional distress. It really happens after the fact where we start to see differences. And indeed, when we look at the long-lasting distress, there was a significant association with the RSI in the sense that control subjects only incidentally experienced long-lasting distress, where this frequency was labeled sometimes with severe insomnia. We also went on to do a neuroimaging study in relation to this long-lasting emotional distress. So in this neuroimaging study, we asked control subjects and insomnia patients to recall emotional memories from at least a decade ago. And so this was sort of really old memories, and then asked, okay, so how does the brain respond to recalling that old emotional memory? And compare the insomnia patients and controls. Well, in the controls, we didn't see any activation in limbic circuitries or in the salience circuitry, the two main brain networks that we know of that are associated with processing emotional memories. But in the insomnia patients, we did see a continued activation of this dorsal anterior cingulate cortex, which in turn was also correlated with their galvanic skin conductance response. So indicating that if with insomnia, so insomnia has really a long-term impact on recall of emotional memories, in the sense that we can still see a limbic brain response and continued autonomic nervous system responses to that old emotional memory. So at the moment, I might ask myself the question, where do I go from here? At the one hand, I want to keep my eye on the prize. We need to, translate these findings and ask about risk factors for development of mental health disorders. Is this indeed the main risk factor for insomnia, for them to develop insomnia, for them to develop depression and anxiety and the like? Also, is this useful to maybe help monitor or improve treatment? And yes, I am currently doing some work in that space, and this is what I'm working towards also with collaborative work with Oost van Zomeren. We have got a very exciting new project in the pipelines, but this is still work in progress. And I do also want to plug in a paper by my former colleague Janne Leerse, who showed in her 2022 paper that if you do CBTI for insomnia, so CBT and circadian interventions for insomnia, you're not only helping them to improve their insomnia severity, but it also has lasting effects on depression severity. So, for example, so this is a very exciting study if you want to read more about that particular area. But for now, I want to keep a little bit on the more basic research question, asking what really is this maladaptive sleep? Because I started my presentation with that hypnogram of a normal sleeper, and normal sleep is already characterized by varying levels of arousability. And we have the idea that it's the arousals that we observe in REM sleep and sort of how low the noradrenergic activity can go during REM sleep. That is really an important factor for overnight memory consolidation and regulation of emotional distress. And so that's the main aim at the moment, to really elucidate, is that really the key to maladaptive sleep. And for that, I want to first continue on with a study that was led by Tensi Kao. So I was involved, but this work was really importantly work by Tensi. And this was work done at the Woolcock Institute, where we asked people to spend 2 nights in the laboratory. And in this first night, people were allowed to sleep according to their habitual sleep patterns. So they had sleep diaries and wrist actigraphy. And based on that, we set their lights off and lights on times. And from that data, we extracted the hypnogram and also the EEG spectra. And as we all do these days, we just asked a machine learning algorithm to classify the insomnia subgroups based on this data. So for the results of that study, the very first group, which was roughly a quarter of the subjects, we found a very highly characteristic insomnia subtype, in which we saw very low sleep efficiencies, below 70%, only 5 hours on average total sleep time, more than 2 hours wake after sleep onset, quite markedly reduced delta power during non-REM sleep. And then finally, also strong increases in the arousal index, all relative to controls. We call this group the disturbed sleep and delta power deficient subgroup. Next, we also found a very interesting subgroup there, where based on the hypnogram variables, so basically the sleep efficiency, total sleep time, wake after sleep onset, or even the arousal index, we could not find distinct differences as compared to healthy controls. However, within that sleep that they still had markedly reduced delta power, shown here in this blue graph, in this blue bar. So yeah, within that sleep they had normal sleep, but within that sleep they had delta power deficiencies. And then finally, I think this is also a very interesting group. There were no observable differences in terms of their hypnogram variables, but also in terms of their EEG spectra. So quite markedly the same as compared to normal sleepers. And we call them the normal sleep and normal delta power group. So we are currently studying these groups in more detail, really focusing on these arousals. And that is also because on that second night, we asked them to spend 2 hours less than their habitual sleep time. So we had an individual that had a habitual sleep timing of 7 hours. On that second night, they were only allowed to sleep 5 hours. And this was done as a model of what you'd normally do in a CBTI, where you do sleep restriction, where you crop the time that people can spend in bed and sort of help to consolidate that sleep. And indeed, by doing so, we could markedly decrease the arousal index, and focusing on this red group, that really characteristic stereotypical insomnia group, their arousal index almost halved. But even in the subgroups that we could not necessarily distinguish from normal sleepers, we could also see a decrease in their arousal index. So we were quite happy with that result, and we're currently studying whether, if you do sleep restriction more long-term, whether that has also lasting effects on this arousal. I want to end this talk today by highlighting that some of these ideas, or almost all of these ideas that I've been talking about today, have been written up and published in this paper, from which I was very fortunate to work together with some excellent collaborators. So if you're hungry for more neuroscience, please refer to this paper. And I'll be happy to take any questions. But before I do, I just want to acknowledge my institutes, the Macquarie University, Woolcock Institute, but also the Netherlands Institute for Neuroscience, for which I did some of that work that I'm presenting today. And also, I've been copying this slide over and over since 2013, since I've started my PhD, just highlighting that the work that I've been doing so far has been really supported by lots of other people. So I want to thank them as well. Yeah, happy to take any questions now.